Well, welcome again. Thank you so much for joining us today for our Systems for Action Research and Progress webinar series. My name is Carrington Lott, and I am the Deputy Director at Systems for Action. If you are new to our Research and Progress webinar series and don't know who Systems for Action is, we are a national research program office funded by the Robert Wood Johnson Foundation. We have been funded since 2015. And one of our main activities at Systems for Action is to develop and release annual funding opportunities, soliciting ideas for novel research ideas and ways of aligning the medical, public health, and social service systems. So every project funded through Systems for Action has this focus and has submitted successful ideas that we think are very innovative and novel for aligning whatever systems that they have proposed. So today you're going to be hearing from one of our teams that was funded in the 2025 funding opportunity that we had that just was funded recently at the end of 2025. And this project was started November 2025. So this is the first time that you're hearing from them. This is where you get to hear about what they proposed to do and what they've done so far and what their future plans are as they close out their 12-month project that they have funded through Systems for Action. So this team today is from the Homewood Children's Village in Pittsburgh, Pennsylvania, and they're going to be talking about aligning community care through embedded school-based systems. Before I hand it over to the team to introduce themselves and tell you more about their project, just a few housekeeping items to go over. All of these sessions are recorded, so we will send you an email after today's session with the recording from today and the PowerPoint slides and any other resources or materials that are shared during the webinar session. The other item is that we do save time at the end of these webinars for Q&A. So if you have any questions that come up during today's session, please locate the Q&A box at the bottom of your Zoom screen and enter your question in, and we'll make sure that we save time at the end to ask the team what your questions are so that they can answer them. If you put your question in the chat, we will do our best to see it. But if you put it in the Q&A, it will make it certain that we will see it and be able to address that question. So please use the Q&A box if you're able to. With that, Walter, I believe I am done with my intro. So I'm going to go ahead and hand it over to you.
Thank you, Carrington. Good afternoon, everyone. It's wonderful to have you all here. To talk about our project. I'm super excited. My name is Walter Lewis. I'm the president and CEO of the Homewood Children's Village. I'm joined by my colleague, Raymond Robinson, who's our senior director of programs. And we're excited to talk about our project that we've coined Access. And I want to start with talking about the problem. I mean, Carrington laid it out that all of these projects are dealing with this sort of system fragmentation. But I'm sorry, before I get into that, I'll tell you a little bit about myself. So again, I'm the president and CEO of the Children's Village. My background is in computational biology. So I came kind of from outside of the social services sector, but sort of really was always doing some stuff like this on the side. And so decided to sort of make this my full-time sort of activity. I've been at the Homewood Children's Village since 2012. We'll talk a little bit more about the organization a little bit later on. And I've been CEO since 2018. I've got expertise in collective impact, partnership facilitation, and I also live in the neighborhood that we serve with my family, my wife, and 4 kids. Now I want to talk about the challenge of this system fragmentation. So fundamentally, structural fragmentation of these systems is equivalent to racial exclusion. We've got Black families who've been dealing with systematic issues in our society, at the center of this fragmentation. We have these systems like public health, medical care, public school systems, social services systems that don't talk to each other. And families are left, dealing with the burden of this fractures of systems. And we know that this has an impact on health, right? Our health is largely shaped by social factors. It's not just a matter of decisions that you make, but we know economics has a huge role impacting our health outcomes. Access to education and the quality of that education makes a difference. Healthcare access and the quality of that healthcare. Also, the neighborhood and built environment. And lastly, social and community context. Now, I'm going to give you an example of how this plays out in the historical context and why issues like this sometimes disproportionately impact Black families. So if we take policy and practice such as redlining, right? And so this is a map of the city of Pittsburgh, and it looks at formerly redlined neighborhoods with 50% or more Black or African American residents. This is from 2021. But what you can see from this map is there's, a disproportionate relationship between the neighborhoods that were redlined that are disproportionately Black and adverse outcomes for the residents. So in this particular map, we're looking at the sort of residential security, hazardous, and decline of neighborhoods. But there's similar maps where you can look at health disparities, you can look at environmental issues, environmental justice issues, and we see the same kinds of overlays. Now, when we think back to those social determinants, by simply restricting where a person could live, we're impacting their economic opportunities as the value of those homes, right, was not able to be realized fully compared to many other residents. We're also seeing impacts of their health, right? If there are, disproportionate challenges related to health in some of these neighborhoods, environmental concerns, and folks are forced to live there, they're going to be dealing with the brunt of that. This also impacts your educational outcomes, the access to the schools that you have, and the individuals that you're able to socialize with. So just looking at redlining alone as an example can show you some of the reasons why we see the disparities that we see today. And so again, the structural fragmentation leaves families having to deal with the weight of this, right? So the legacy of policies and practices like redlining, and this is just one of them, we have our systems operating in silos, which create barriers for navigation. Many of these systems are difficult to navigate on their own, let alone when you have to try to navigate between multiple of these systems. Oftentimes, staff that are working in these systems are also overburdened as well. Some of the ways that the systems operate when we're trying to connect families to resources, they're not necessarily smooth. Some of the processes are outdated, and the individuals working the systems can be taxed as well. There's also this inaccessibility issue that allows for many low-income families to have to pay what we call a time tax, right? So if you imagine, you've got a doctor's office that closes at 5 p.m. or 5:30 p.m. So, if you're an hourly worker, a wage worker, and you've got to take off work, and miss out on wages just to take your child to the doctor. And let alone if you have multiple children, that's a tax that oftentimes people are having to wrestle with. And these sort of barriers often means that the health disparities remain unaddressed, right? Because people are underutilizing many times services that exist right within their neighborhoods. And so for us, we wanted to propose what could a solution look like? And so we wanted to look at what would it look like if we developed a school-based point of service system as a solution. So we take schools as a starting point because our children are all flowing through some sort of school. The average student, average young person is flowing through a school system. And so what if we use that school and we use technology to allow that school to be a point of service connector to social service systems, medical systems, public health systems, all through the sort of ease and use of a digital tool. As we talk about this tool, we think about the idea of not just being able to know what resources are available. There are a lot of resource lists out there, websites you can go to see what's available. You can Google search, but it's still with the separation of these systems, being able to register and sign up and make appointments for all of these different things is an undue burden that families also often face. And so how can technology streamline and simplify that process by allowing you to have a single login, a single point of source that can connect you to all of these resources? And again, it can happen right through the school. And the idea here is really, how do we shift the burden from families to institutions? At the end of the day, those of us that work in these institutions, we get paid to be able to provide high quality services to families and individuals who are in need. And so if anyone should be facing the burden of trying to align things, it should be us as systems folks. And the other thing that's really critical about this solution is our design is being driven by lived experience of the families and the students who are having to navigate these situations, as well as the staff as well who are having to deal with these situations as well. And so for us, our study, we wanted to look at first, can we make this work? Right. I think that's the most important piece, is can we actually get young people connected to services? Now, for the purpose of our pilot, we wanted to focus on medical services. Part of the reason we wanted to focus on medical services is because of the sometimes challenge of dealing with compliance issues like HIPAA, release information, legal issues when it comes to navigating the medical field. They can have some of the most difficult systems to even interface with the idea that if we can make it work in a medical context, that it should be able to translate pretty well to the other kinds of services that we could provide within this context. The other thing that's important about feasibility for us is, for us, it's not just about the feasibility of the app tool. Technology is great, but it's really about the sort of systems, the mechanisms, the process, the workflows that you're establishing to make sure that the technology is doing the right thing. And so we're using a human-centered design approach. And before we build anything, we're testing that out in the real world using very low tech sort of solutions, paper, pencil, spreadsheets, basic things that are available to test the mechanisms and the workflows that we're trying to establish in the technology system. So again, step one is we want to evaluate, can we make it work? Are we actually able to get kids connected to these services using the point of service system? The second piece is acceptability. And this is really critical, asking the questions of will staff and families trust and use it? There are a lot of tools that get built every day, a lot of tools that get deployed every day in systems, especially big systems like school districts. And one of the biggest challenges they face is the number of individuals who are actually utilizing the service that they're paying for. And so what we want to understand with our tool is, do we see families actually trusting it, using it, taking full advantage of it? If not, why? If they really are loving it, what is it that they love about it, so that we can use that information to help us scale. And so we'll be conducting surveys, interviews, and then also looking at the actual data from the platform usage as well. And then the last piece of our sort of study is really looking at the early impact. Are we actually improving access through the use of this tool? Are we seeing any increases in immunization, screenings, timings, et cetera? And a lot of this impact right now is going to be focused primarily on the medical services that we're trying to connect kids to. And specifically in the pilot, we're going to be utilizing the mobile clinic to increase access, to make sure that our kids are connected to that. Now, once we, conduct a study, the idea is to really move from evidence into action. And so the first piece is we want to obviously continue to use the tool in our own schools. So we serve children in schools every day, and we want to be able to promote usage across our school district, and then offer a low-cost licensing model that other organizations, individuals might be able to take advantage of should this solution be something that meets their needs. We also want to develop community-facing products. We want to make our findings accessible via short videos, slide decks, briefs, and other community-facing mechanisms. And part of the reason of this is because so often research gets conducted. We go into the community, we do community-based research, but then we don't necessarily disseminate in the community, or we disseminate findings in the community, but not in ways that are easy for everyday people to understand and digest, right, in usable ways. And so we want to make sure that this project is actually putting that information out, because a lot of the people that we think can benefit from this are community-based organizations, schools, other health facilities, clinics, other federally qualified health centers. These are people that can use it, and they're not always digging into the latest research or the latest journal. So we want to ensure that they get access. Lastly, we want to have a replication guide. The idea here is that what we're positing is that the technology that exists to make this happen is accessible. We believe that this can be done at relatively low cost. So for organizations that have tech talent or access to tech talent, the replication guide will be something that they can use for them to replicate this on their own. They don't have to use our tool or our product. They could replicate this on their own in their own context, and maybe even find ways to further advance it. The licensing model exists for institutions or entities that may not have access to that tech talent, but might be able to seriously benefit from what it is that we're providing. And so while I'm the person talking a lot today, I promise I am not the only person that makes all of this happen. So we have a wonderful team of partners that have come together to, drive this project forward. And I'm super excited and honored to be working with these folks. And I'll talk a little bit about our organization and each of their roles. So, but first, all of these partners we have very strong relationships with. They've got strong technical and community capacity amongst the partners. These are folks that we have a history of collaborating with. Every partner that's listed here are folks that we've worked with for many years prior to the launch of this project. We've also had some prior experience and conversations and attempts to do some in-school school-based health services. And then there's a commitment to partnership beyond the grant, which is so important because it allows us to really dig in for the long term. And as we're making decisions and having conversations and trying to advance the work, everyone's thinking about not just the end of the grant cycle, but we're thinking about the long-term impact on children and families in our community and beyond. So Homewood Children's Village, we're the lead partner and convener. Homewood Children's Village has been around since about 2010. So we're going into our 15th year of operation. We are based in the neighborhood of Homewood, which is on the east end of Pittsburgh. Homewood's a community that's dealt with a lot of the challenges and disparities that we talked about in some of those earlier slides. And our organization exists to support children and families holistically from cradle to career. And so when we think about health and health outcomes, it's really critical to our work because these are often things that schools on average are not talking about. People are not always talking about when it comes to their outcomes. One of the things I'm also excited about is our staff also brings a level of technical expertise as well. So I mentioned, my background in research, computational biology, computer science, and things of that nature. But we also have our data and technology manager and other staff that bring technical expertise. And our data and technology manager actually helped create an app earlier in his work with the Homewood Children's Village to help support college access and career readiness for young people. And then our organization boasts really strong relationships with schools and families. So we have staff that are largely hailing from the community. I mentioned earlier, I live in the neighborhood. A lot of our other staff members are from the community or very similar communities or nearby. And so that brings a depth of relationship with individuals already. Folks are in the schools every day working tirelessly to support our families. And so this, we think, gives us really, really great positioning to support and lead this work. The University of Pittsburgh School of Public Health is our research and evaluation partner. They bring a huge amount of technical capacity and support in this work. I always joke with our lead research partner, Dr. Dubowitz, I've got research background, but a lot of my research was, I was doing bench science and writing programs and writing models. It's very different from, working with, humans and sort of designing studies. And so I lean on her expertise a ton to be able to make sure that this project goes forward. It's also a huge benefit that, Dr. Dubowitz has a history of long-term community research. I talked about this idea of this long-term commitment. So she's been the leader of this project called Fresh that she's been working on for over 10 years, doing research in communities in Pittsburgh, particularly in Homewood and the Hill District. And so that really positions her really strongly as a research partner. It's not every day that you find research partners that have that level of not only expertise in working in community, but commitment as well. We're also actively working on an entirely separate research project on urban flooding, which has been in Homewood as well, which has really helped, I think, kind of anchor and develop our relationship and partnership. Primary Care Health Services is our federally qualified health center right in the neighborhood. They raised their own funds to upgrade their mobile medical unit, which we're using for the purpose of the pilot to connect students to medical resources and supports and immunizations and things of that nature. They've done prior work in school-based health services. So they've been in schools running school-based health care. It's something that the organization's committed to. They've dealt with in the past challenges around billing and really keeping it going without outside funding. Obviously, there's been some changes in terms of the way billing is done. And so we're confident that as this project goes forward, that we're going to be able to advance the project in ways that allow for billing to be able to cover the cost of the services fully that are being provided. And then lastly, they also provide other services beyond the immunizations and the things provided in the mobile unit, such as mental health, dental, pharmacy, and several other services. Function Dynamics, our technology partner. So this is our lead web and app developer. They've got experience integrating systems, prior work with HCV and our data system, and also a commitment to functional innovation and bringing value to customers. So this is critical because a lot of folks develop technology that looks pretty, but it's not necessarily the most functional thing. It doesn't really help. It doesn't really solve the problem. And so we have a tech partner that's really committed to bringing value, not just to us as an organization, but ultimately to our end users. And lastly, Pittsburgh Public Schools, we've been working with them since 2012 on our Community Schools Initiative. We are the lead partner agency for several of their schools. They have 6 other community schools within the city, tons of other schools, but 6 other community schools. And again, they've got experience in prior school-based health services. And then we also have a lot of principal and staff support, which is critical to make this happen, right? We're going to be working with principals, working with school nurses and other school-based staff to make sure that young people are able to be connected. And so I'm going to get ready to turn the floor over to my colleague Raymond, who's going to go into sort of deeper detail about the community schools and the context that it provides to why it's important to this project and its success.
Good afternoon, everybody. Thank you, Walter, for the handoff. Yes, really excited to share kind of this project and my role as part of it as well with this audience today. I'm Raymond Robinson, as Walter mentioned. I've been with the Village since 2019. I've served in several different roles and capacities over this last several years, currently serving as the Senior Director of Programs. That makes me basically in charge of all the programs we have, whether that's our Village Scholars work, where we're working to support students in school and in out of school space. We have the Leadership Institute, where we're working with students and families to create or empower them to be community leaders. Or even our family engagement work that we do through our family nights, where we bring families out for a communal space, dinner, and provide workshops and activities for them to come together in. But this work, this project is specifically tied to our community schools work. And so as Walter mentioned, we've been working with Pittsburgh Public Schools for several years with community schools. We serve as the lead agency for 3 of their schools. And they're all situated in the East End around our Homewood community, kind of where our home base is. I have a team of site managers who are responsible for carrying out the strategy in each of their schools. And so what is a community school? In a nutshell, it's a partnership, and it's looking at how do you make these schools, instead of being a building where kids go for 7 hours for instruction and they go home, it's how do we look at our school buildings as these community assets. So it's a partnership between the school district, and we work with community resources so that we can kind of offer programs and services that aimed at academics, enrichment, health and social supports, youth and community development, family engagement, and they're all based on each school's individual needs. So one of the things you'll see when you look at needs is sometimes they can vary even in a short distance. So we've got schools, most of our schools are not that far apart from each other, maybe a mile, 2 at the most. But sometimes even within that very community, they'll have different needs. I know one of our schools, talking to them a few years ago, they had a specific issue with a lot of families experiencing homelessness. And so how do we connect resources to that? Another school, similar school, also had issue with transportation. The photo you see here is one of our efforts working with the city and the school to try to encourage kids to safely come to school on bikes and rollerblades and scooters and whatnot. So the idea, again, with the community schools is how do we use the assets and the resources that are in the community to address those specific needs? And again, while the schools may have various needs, we do have a similar structure that we use overall. And so you see here on this slide, there's 6 key practices of community schools. And these practices are all integrated together to kind of form this community hub. And so one of them is obviously expanded and enriched learning opportunities. We look to have collaborative leadership, shared power and voice, rigorous community-connected classroom instruction, integrated systems of support. We want to create a culture of belonging, safety, and care. And we want to have powerful student and family engagement. Now, obviously, I'm not going to get into all of these key practices today. If you want to come back for the Community Schools 101, we can do that. But the graphic to the right, which again, I know is kind of small here, but it kind of shows how each of these key practices kind of work together to create this community school. But for today's purposes in this project, we want to talk about one specific key practice, and that's our integrated systems of support, right? And see, these are those essential systems like health, mental health, and social services that we attempt to coordinate so that we can provide our students and families these opportunities to address the challenges that impact their learning and development. So obviously, I think you can see where this project that Walter has laid out specifically ties into this key practice. And so what's that look like on the ground, right? And so we're talking about what is a community school? All right, we know what the community needs are. What are some things we do? So just for an example, one of our schools, Westinghouse, it's a 6 through 12 school. We noticed a lot of our families and our students were hungry, or students were hungry during school. Homewood is kind of a food desert, no real readily affordable access to fresh fruits and vegetables. So we worked with our local food bank. We've also partnered with some of our local urban farms so that we can have an on-site food pantry for the students in the community. And it started out as just some place for students to get snacks during the day. Now we have, I think, twice a month opportunities for families to come out and get a bag of groceries to take back to the home. Another opportunity, kind of explain a little bit what this looks like in practice. I had an opportunity to go to Los Angeles for a community schools conference. We saw a school that faced similar challenges as we're talking about with limited access or difficulty for families to access medical care. So they worked with the local healthcare provider, and they actually constructed a health clinic on their campus. So the front door faced the community, so the community had access to the clinic, and the back door connected straight to the school. And so students could go right to the school to kind of get their checkups and their doctor visits. And again, that really kind of helped solidify what a community school could be for me when I was out there. Like, oh, this is literally bringing a community health institution to the school. And so with our project, we're looking at, we don't have a physical construction, but working with our partner, they've got the mobile clinic. And so we're really looking at how do we connect our kids and our students through our community schools team to the resources and services of the provided by the mobile health clinic. And so we start talking to our schools, we talk to our staff, and we ask them what are some of the current challenges that they face and kind of in this space. And Walter mentioned, I think, immunizations earlier, screenings. And so one of the things that happens with that is kids can't come to school sometimes. It literally prohibits them from coming to school until they get certain things taken care of. I think we reached out to one of our schools, and they shared, I think earlier this year, they had at least over 50 students that had some type of a medical need that potentially could be a barrier to them coming into school. And so again, we know some of the implications of that, right? You can't come into school, especially for a kindergartner, and you miss a day, you miss a week because your families have a hard time getting those done. You're going to get behind the ball right from the gun. And we don't obviously want to do that with our young kids. We also know that some of our parents, they get the recommendations, the school nurse will send something home. Hey, your child needs to get a checkup. And again, due to some of the fragmentation that Walter talked about, some of those parents just don't have the readily availability to get those kids to those appointments and whatnot. And again, so those kids now are missing out on the care that they need. Another area, student athletes, they always have to have physicals to participate in activities and sports. Again, that can be a barrier. Sometimes kids, they have a long time. It takes a while to get the physical. Now they're missing out on these opportunities in school. Also mentioned in here, we have some of our kids having behavioral disruptions. And I know this project is more geared specifically to medical care, but behavioral health, our partner also provides behavioral health. And so sometimes, again, our schools don't have the resources to address those behaviors in the school. And so these behaviors go unaddressed, and they obviously continue on and spiral into further problems. And again, another challenge, we just have students who are unable to take advantages of these resources. So notwithstanding the historical implications of underutilization and under resources in the community, we do have a lot of rich resources. However, we don't always have people connected to them, and there's been a challenge with that. And again, another issue is when the schools reach out to the families, they suggest, hey, this is a service or a problem or something that your child needs. They don't really have an easy, readily available way to follow up to see, did the child do that? Did the parent take the kid for the appointment? And so again, these are all challenges that our schools have already talked to us about, that we're hoping to address with this project. And so we get this project up, we get this into the hands of our school staff. What's this look like, right? What can we impact? What's that look like for our students and our families? So one, can we reduce the number of students who have delayed enrollment, right? Again, we know that that's obviously going to set students back. If we can ensure that, hey, before you even get into the school for that first day, hey, you know what you need. The mobile clinic can be coordinated. You can come to school with your kid, get that initial immunization, and get to school on day one. Timely well visits, right? Again, so even surpassed your initial enrollment, but we know our students are expected to get our regular checkups. Again, this is one way to do preventative care. And again, we know when we miss those checkups, our kids have more health implications, and it has negative outcomes for their academic outcomes. Can we limit the number of students on medical exclusion, right? And so sometimes when parents aren't able to get those mandated immunizations, they can't come to school. And so again, how do we limit that? How do we prevent our students from failing or falling behind academically? Again, the more times our students can stay in school, the less they're going to fall back. I know the example they shared at Mendez High School in Los Angeles. Right now, in the past, and even in my experience, if I had to go to a doctor's appointment, my mom didn't drive. We usually had to take 2 buses to get to the doctor, 2 buses to get back home. I missed school for that day, by and large. But with the mobile clinic, the experience what I saw in Mendez, the student could come to first period or come to school, go to the mobile clinic to get his checkup, and be right back. He might miss 1 class. And so obviously that's going to keep our kids in more time and instruction time. That's going to help out. And avoiding stigmatization. Obviously, when kids missing school, kids got health issues. And we know how peers can be. And again, how do we address some of those medical things up front, be preventative, keep them in classroom? We can avoid that. And then also some of the more serious implications. We want to keep our kids out of the juvenile justice system, right? The court system. When kids miss too many days, that triggers truancy proceedings. When kids have behaviorals, they can get involved with the juvenile justice system. So again, making sure that our families, again, through pretty incredible idea here, is if we're able to use technology to connect our school staff with our families to the resources that we already have, we'll hopefully be able to keep these kids in school, on task, and learning.
Thank you, Raymond. And before I go into the next slide, I just want to add, for context, Raymond talked about the community schools model, and it's a phenomenal model and a phenomenal opportunity to support the integration and connection of these types of systems, right? But the beauty of it is also that there are community schools all over the country. Raymond gave the example of Mendez High School in Los Angeles. There are other community schools in Pittsburgh, others across the state. Not sure where everybody's from on the webinar, but it's very likely that there's a community school in your state, in your county, and possibly even near you. And there are many other schools that are very interested in becoming community schools. So it's a model that, should we get this project to work, right? Should our research pan out? And we're starting to see really positive improvements in utilization and all of those things, is something that could scale quite rapidly in the community school context, because there are these schools everywhere. And to Raymond's point, where you have a school context that already has available resources and you're simply putting technology in place that can kind of align them and make it easier for people to navigate, that's what we think that this has the greatest opportunity for scale, which is, again, a big part of why we're not only looking at our own tool, but how can we get this information out there so that regardless of whether or not people use our tool, that we're advancing the science of what we're doing in this context, because we think there's a huge opportunity to be able to connect these systems through the community schools lens. So last, I want to, before we, I guess, go to Q&A, I want to talk a little bit about progress to date. We're very ambitious. We were hoping that, even though the funding award didn't time up with the start of the school year, we were very hopeful that we might be able to, sort of do our first pass of the mobile clinic right at the start of the school year. While that was unable to happen, we still have been able to make great progress in terms of working with our health partners to get things aligned. So currently, our major things that we're excited about is working through the tech specs of the application that needs to be developed. We've met with our tech partner. We've brought our community schools partners to the table. They've talked to their school partners, and we have our basic kind of tech specs laid out for what this app will need. And then we started to do some initial work on the permission specs. One of the biggest challenges is thinking about permissions, especially when you get into a medical context and thinking about things like immunizations, right? You've got to have a really robust permission system to make sure that we're not putting our provider, particularly our medical provider, at any kind of risk or liability because the permission system was not, super well designed. So we've been going back and forth with them, their legal, and trying to get an understanding of what's the best design that makes it easy for the staff, the parents, the families, the individuals, but also provides the right protections. And so we've got some initial permission specs based on some of those early conversations completed. And so that process is moving forward, kind of as expected. Again, working through legal HIPAA data integration with our health partner. One of the things we're excited about is this partner has experience working with APIs, which allow for data to be shared kind of on the back end of these systems. With the tool that we're planning to design, that we're working to build, the idea is, again, not just to know that a resource is available, but you want people to actually be able to book the appointment, right? If a kid needs immunization, we want this tool to be able to book them their appointment so that the medical provider actually has them on their schedule and they can miss that step of, which often is where referrals get dropped, is someone gives the information, oh, call this person, schedule the appointment, but that doesn't happen. Or if the staff person has to do it with the parent, sometimes that doesn't happen. So again, we're working through sort of the data integration pieces to look at how will we pass data between our system, their system, what data will we keep, what data will we not store in our system that we'll simply just pass forward, and trying to work those things out. And so that is in progress. Also, as I mentioned earlier, human-centered design is big for us, and actually sort of designing in practice what we're planning to build in technology is really important. So we've done some small scale pilot interventions where we've been able to make connections to certain resources, and we've been learning from those processes, right? Because the idea is we're going to need to replicate what worked in our system, and what maybe didn't work or what was convoluted or cumbersome are things that we need to address within our system. So just as an example, we were able to get, I believe, about 50 families or so transportation to an event that the Steelers hosted, where they provide all kinds of resources, some health related, and other social resources that, again, for many of those families, without the transportation, would not have been able to have access. These are the kinds of things that, again, when the system is fully developed and to scale, should be able to be sort of point click of a button for folks to be able to get registered and get access to these types of resources. In terms of next steps, some of our immediate next steps is really delivering the first beta version of the point of service system. We want to be able to put it in the hands of staff and families to be able to interface with, to give us feedback. We believe that this is an iterative process. We don't believe you go in a dark corner and build an app and then hope for the best. And so there's going to have to be iterations. And so we want to get that first version out so that folks can begin to test it and see it in real time and give us feedback before we continue iteration. We also have a really exciting new opportunity. Our partner from Primary Care Health Services has been in deeper conversations with the county health department. And so we think that there's some opportunities that we may be able to align around their immunization efforts and be able to leverage even more of their capacity to be able to support this initiative. We're super excited about that because we've always wanted to have a partnership with the health department on this project, and they've been supportive. But this is a great opportunity that's very tangible for us to work together. And we think that this is also scalable as well, because most county health departments have similar types of programs that often have federal funding, sometimes state funding, that can really help support these types of initiatives and interventions. So that's where we're at to date. We're super excited about the project as a whole, where we're headed, and the implications of what's possible when we can get all of these systems actually working together on the behalf of kids and families, and not forcing them to have to navigate the disconnected nature of this fragmented system. And so with that, I'll conclude kind of our presentation and I guess pass the mic back to Carrington. Thank you.
Thank you, Walter and Raymond. That was exciting for me because we haven't touched base in a while. So it's great to see all the work that you've done and hear a little bit more about those relationships that you're developing. I am going to ask a question first before I hop into Q&A, which I see lots of really good questions coming in. So lots of engagement here. But you mentioned on the last slide just some hiccups, I guess, in the timeline in terms of having conversations with the health partner about security concerns, about what data is being shared and stored. And I'm just curious if you're thinking about developing some type of implementation guide or documenting sort of those lessons learned for other organizations that want to do something similar so that they don't experience the same kind of timeline barriers.
Yeah, thank you. No, this is great. I think the short answer is yes. It's the reason that we decided to intentionally start with the health resource first. I think we could have built this system without the health partner at the table, at least as strongly, and the system could have worked. But we wanted to start with what we felt was going to be the most challenging part first, because the idea is that if we can figure this out with the health partner, it's going to be a lot easier to figure this out with other partners. One of the other things is because of the way that healthcare is regulated, especially federally qualified health centers, those regulations are going to carry forward and pass through. Now, some stuff is going to be different state to state, but we think there's going to be a lot of lessons learned from this process that, to your point in that replication guide, will make it easier for other people, again, whether they use our tool or not, but it will be easier for them to be able to take this approach again without having to do all of this themselves, right? They can have something to start with where they could share with their health partner and say, hey, we read this replication guide, they tried this, would this work, for your company? And even if it's not a full yes, it's probably closer to a yes than if you had started from scratch.
Exactly. Generalizable enough. Thank you for answering that. And I'm going to go ahead and hop into some of these questions. Looks like we've got about 16 minutes left. If you are discouraged because there are a lot of questions that have been entered, please don't let that discourage you. If we don't have time to get to all of these questions, we share them with the presenters afterwards to give them an opportunity to respond. We can include those responses in the follow-up email that we share with you. So first question coming in from Chris Hollis is that CDC long-funded coordinated school health programs, very similar to what you're doing now. Has your program benefited from any particular lessons learned from this effort, and or what are you doing differently?
Yeah, so I think we definitely are benefiting in when we think about how these types of things are going to be funded. It's part of what makes us excited about the health portions of the project is that there's a lot of evidence that people have been sort of building over the years about how to do this in a way that can be funded sustainably. And so that's, I think, probably the most exciting piece of this is that there's context that says if you can get the sort of system piece working right, that you can get the funding mechanisms to keep resources like this alive and going long into the future. The other thing I'll say is that some of the other lessons learned is oftentimes there are these funding mechanisms in place, and is again great infrastructure. Raymond talked about this. The resources are there, partners are ready to go, but sometimes folks struggle with actually getting people to take advantage of the resources. And it's that communication barrier, that connection barrier that often happens where you got a resource, you got a person in need, but somehow we're missing the mark. And so, part of our desire is to kind of create a tool that helps to facilitate that connectivity and that access. And that's, again, a lot of what we'll be testing. But again, great question. And again, it's so great that there's been so many programs, resources, services, and funding actually behind these types of initiatives.
Wonderful. Yeah, and just to reiterate that one of the main focuses of this recent funding opportunity that we released was how can your approach align these systems in a way that dismantles systemic racism? And while there might be other programs that do something similar. Do they have that same focus? If yes, great. If not, like what can we learn from what they've already done? But how do we make sure that everyone has access and that we're reaching the groups that may have been missed in other approaches? Second question, also from Chris. Why did you go with a mobile medical unit rather than a school-based health center?
It's a great question. I love this one. So we've actually started trying to do school-based healthcare, and we ran into a number of challenges over the years. So one, historically, our partner had actually done this, and again, they struggled, at least back then, this was probably 10 plus years ago, to make the numbers work in terms of billing, right? The way that their billing situation was structured, it just couldn't work financially. They were taking too much of a loss, and so they had to pivot. Um, so we've got some experience there. The second piece, though, is I think it was probably about 5, maybe 6 years ago, Raymond. Might have been 7 now. Time flies. But our school district and our community schools initiative attempted to bring a school-based healthcare model to Pittsburgh that didn't really take off the ground. There were a lot of like bureaucratic stuff, red tape, different things of that nature, and it didn't end up passing, right? And so we weren't able to bring that to bear. So there are often barriers that exist to doing school-based healthcare, right? You got to have the physical space. Sometimes there are issues with unions and different things like that when you're trying to bring these resources. The mobile clinic kind of bypasses that for our context, in that it pulls up in front of the school. It doesn't require some of the same restrictions or approvals that it would require if it was a service going into the actual school building. So the number one reason is it just allows us to get off the ground running as fast as possible, and there's literally no barriers. We also think that this is an exciting thing that other places may want to look at as well, who are trying to deliver these types of services, because our mobile unit, we have 3 community schools. If we were going to do school-based healthcare, we probably are picking one school, putting a lot of resources and investment into that one school. Then you got to figure out how to get the other kids to that school. The mobile unit just pulls up on schedule whenever it's appropriate at that particular school. What our point of service system helps to do is to coordinate, so that we're not sending the mobile unit to the school on a Tuesday just because adults, we like to create our little schedules and stuff, right? We're going to do it every Tuesday, but that might not be when kids are available. But using the system, we're only going to send the vehicle where there's actual appointments, so that way we're maximizing the resources available. So great question, but something that we've thought about. Now, I do think that the school-based healthcare model can be a long-term solution, but something like this can generate the data that you would need. Do we have enough volume of students and families taking advantage of it before we make the investment of putting the resources into school-based healthcare?
That is a fantastic point. Thank you, Walter. Moving on to our next question from Natalie. How are service providers connected to the platform, and what is the role of the schools/school districts in determining the service providers?
So this is great. So I'll answer it in a couple ways. First, I'll talk about what we're doing, and then I'll talk about it kind of more generally. So for us in a community schools model, as the lead partner, we're responsible for bringing in partners into the building to address the needs of the students. So as a community schools lead agency, that's our responsibility. Our team is doing that already. So for us, that mechanism kind of already exists. And so there isn't anything new that this system is adding to that process. We're simply using the tool to manage those partners and manage those resources better than what we're able to do without such a tool. That said, we're definitely planning to build the tool in a way that allows interface with partners, because again, the main thing that I would say is different about this tool and our objectives compared to some of the other things that we've seen and have worked with in the past is the ability to actually like book the appointment, to actually make the transaction happen through the same tool. So in order for that to happen, you have to have some kind of a relationship or interface with the partner on the other side. So you've got to understand what systems they're using. So that way, if we've got to build some kind of API connection, we can build that. Or if you can just get partners to use your system. One of the things that I think people have done in the past that often is a barrier is they kind of only do it one way. It's like, well, here's our system. You now have to sign on to our system, use our system. Back to the burden on partners. If I'm managing the food pantry, the food pantry has this own system and then I'm supposed to use yours too, that oftentimes becomes that barrier that sometimes means I'm not fully taking advantage of what you have to offer, or I'm not sending people or responding timely to your requests. So we want to have those things be integrated. So that's kind of how it's working for us. And I think when we get to the replication guide, this is something that we can certainly spend more time on, because if you are a community school, you'll be more similar to us. But we anticipate that there are going to be people who are not currently running the community schools model who will have to think through how will we onboard partners. And we could certainly share some of the same guidelines that we use in the community schools context to support those kinds of organizations as well.
I think that's a great idea. And this is probably a good point to note that we will invite you back to come and present in this series again. And you can share some of those findings, and hopefully you have some replication guides or ideas of that we can discuss at that time. I'm going to move on to our next question. How will the app match students and families to needed medical services and social services? And what data will you use to build and refine them? And then also, who is the one that is using the POS?
Okay, great questions. Carrington, you might have to help me go back through them all because I might not address all of them. I want to start with who's using it. So this has been a robust discussion that we've had amongst our team and our partners and our school folks. The first iteration, we're going to start with, it is school staff that's managing it. We feel like it creates the sort of safest starting point for the tool, because they're the ones that are in the school. They know the students, they know the families, they can sort of facilitate the connections. We anticipate that there's going to be interest, and we're going to be uncovering what that is throughout the course of this project, and some kind of direct interface from parents. And so we're going to work on what that looks like. But the core system in terms of actually being able to book the appointment, that's going to be a trusted school personnel that's handling that. So this will essentially take what their job already is and make it a lot easier so that they can do it at scale and get feedback on what's happening, right? So if I made an appointment for Kevin, right, for the medical unit, I don't need to know all the details of Kevin's appointment or store that in the system, but we can receive back, did Kevin actually go to the appointment, which is, again, data that you often don't have access to when you're making referrals. So you're like, well, I made 1,000 referrals last year. Well, how many of them were successful? We don't know. So that's something that we're looking to address through the creation of the tool. Now, Karen, I know I didn't answer all of the questions. So
the other question was, how will the app match students and families to needed medical services and social services? And then what data will you use to build and refine them?
Yeah. So similar response, by starting with the trusted school personnel. They're the ones. Now, we are looking at kind of a referral process that's a little bit more open. Like, anybody can make a suggestion, right? Like, hey, we think that this student might have a need or something like that. But there's someone in that building, whether it's our site manager, whether it's the school nurse, whether it's the school social worker, who has responsibility for actually making the connections, and so that they can use the tool to kind of facilitate that. In terms of data, again, using a school context, schools already have access to data that they're using to make those determinations. Sometimes it's academic. A lot of times it's like social, data coming from case notes and things of that nature. A student shares something with a staff person. And something that's important as we think about data, we are intentionally trying to keep our system as light as possible. Data protection is huge. Data protection is even more critical when you're talking about minors, and in a school context. That's the thing that everybody's scared of, right? From the health partner to the school district partner. So one of the things that we're working on diligently is to have a process where we're storing as little data as possible in our actual tool, and we're more so passing data, right? So if the school has information that is protected on a student, we don't necessarily need that in our system. We just know that a trusted individual with access to that information made the referral, because the system is really for that school and that school partner. And so that allows us to not have to store and hold all of that information, but still have it come from a trusted source.
Thank you. I think you've hit on all of those questions. And I think, based on my limited experience of being in public school, because my son just started kindergarten this year, what a valuable resource those teachers are too, because they really get to know those students. And so using them as a connector to the person who is in charge of using the POS in the schools, because they know they kind of have a pulse on what those students need. Moving on to our next question. How will you collect outcome data for the program evaluation? What parent consent rate do you anticipate for collecting research data in your settings? And it looks like you've got a research team partner here that is answering some of these questions for you and helping out, which is so helpful. But I'm asking this question out loud anyway, just so that everyone else can hear your response.
Yep. So our response, she got it covered in the chat. I'll take the piece about like, what percentage of parents. We do a lot of research, as an organization. Sometimes in the way we talk about it, we don't use the word research because sometimes people it has just a negative connotation for some people, especially in our community where there's a history of people doing research like to us and on us and not like for us or with us. And so we think about it as learning, right? Like I often say to people, if we knew everything that we needed to know about addressing these problems, they wouldn't exist, right? We'd be doing it. So there's still more to learn in order for us to be able to do this well. And so we have to learn. And again, good research is a way that you learn, right? What works, what doesn't work. Even when something's good, we talk to staff about, you still need to study why is it good, right? Like, why did it work? We need to know so we can replicate that success. So because of that history, we don't anticipate really any major barriers. We collect data from families. We do surveys all the time, even when it's not like formal research. We're always collecting information and talking to families about stuff. We're also very sensitive and not like over surveying people, right? Asking them the same questions over and over. So where there's data that's already being collected, we try not to recollect that same information. And we're going to be limiting and focusing the questions for this particular research aim very specifically. And the other thing that we find is very important is the people that you're asking questions, when they're directly able to benefit from the project, it's a very different scenario, right? If it just is random, there's no relationship, that's where you get a lot of those questions like, whoa, why are you asking me this? But if it's like, hey, you said that your kid could benefit from these medical services, we need to ask some questions to make sure that it's working well, that it's doing what you needed to do, folks are much more willing to answer those questions. Also, the little gift cards, they help too, right? They help too.
Thank you. I think we have time for maybe one more question. We'll see what we can get to. But the question that I'm going to ask next is from Angeline. You mentioned at the very beginning of the presentation the low cost licensing. And so this question is, who's going to pay for that? Is it the families or the organizations?
Definitely not the families. I think back to my earlier point, we want to shift the burden from families to institutions. So I think to me, it would not be good to say, yeah, and then you should pay for our mess that we've created as the people who design these systems. You should pay to solve it. That's to me the wrong answer. I think the system should pay. But again, by making it low cost, again, my thing is we're not trying to tax the institutions either. The point is, can we make this work? The low cost is so it can keep working and it can be funded, and we don't have to go around shaking the cup just to keep this tool funded and fully supported. Because again, once it works and it's in the hands of people, people going to ask questions. They're going to want updates. They're going to want, well, fix this button. It's not where it should be. This is a little glitch. And so you're going to have a team of people who are dedicated to actually doing that. And so that's some of what the cost will go towards.
Great. Thank you so much. I think knowing we have probably a little bit less than 1 minute, I'm going to go ahead and close us out. I know we still have some great questions that came in. So Walter and Raymond, we'll send these to you after the webinar. Hopefully you can form some kind of response in text, and we'll share that with everyone via email after the session. But thank you so much for coming and giving us, I guess, inviting us in to your project and what you're doing and letting us learn with and from you. And we're excited to follow you along on this journey and support you from afar. And to everyone that attended, thank you so much for coming and listening. And we hope to see you next time. I hope you have a great rest of your Wednesday.